one of the things that really bothers people in Fareham is when they hear about things like this morning on Radio Solent. It said that 3 times in the last 11 days, between the 28th of October to the 7th of November, there was QA had a problem, and so people were taken to either Chichester or to Southampton, which I know is the plan. Now, in the next 20 years, we are going to have a huge increase in the amount of homes that are going to be in southern Hampshire. Fareham is going to have at least 8,000, Eastleigh's having a large amount, and you've got this problem with GPs. We've got this problem with QA already having difficulties. We've got the situation with rental payments to the Community Partners for Health in Fareham, at the Fareham Hospital, Coldies, which does not have any beds now. And then we're going to have this huge influx of homes, probably people. They tell us it's because the people are already here, but you know, I have my own views of that. That's neither here nor there. But people in Fareham are very worried about what's going to happen with in the next 10 years. And I know you might be going to tell us about this, so please forgive me if I'm jumping the gun. But this is something that I hear about daily.
Maybe started.
I would say let's worry first off about the next 3 months rather than 10 years, because we've got winter to get over, and that's going to be a difficult time for us. I think if you look around the whole of the country, everyone is strapped. I think the political environment is such that there isn't a single system in the NHS which isn't groaning under pressure. And the demographic time bomb has definitely exploded. However, Richard and myself spent 5 hours this morning in a series of meetings with 18 people around a table, going through a serious incident review, specifically about those points, about those diverts. The diverts were put in place because it was seen to be not safe, and I think that has to be the paramount point. If you have a system that's not safe, you've got to do something else about it. So we couldn't sit there and say, no, you just have to work harder. We have to keep the population safe. We spent all that time because we're trying to come up with ways, contingencies, ways of mitigating that risk. We didn't have anyone going off to Chichester. They were all taken over to Southampton, and in the end, that was only equating to 20 people moving over. But we're in a situation whereby we haven't really got that huge increase that we would normally find when the weather gets really bad. So today we spent a long time talking about different ways that we can escalate in a reasonable manner to try and get the throughput in the hospital. If you actually go up to the hospital, you've got, as you come up in your big yellow taxi, you've got lots of taxis waiting outside to discharge. They can't discharge because the corridors are full. The corridors are full because the beds are full in the majors and casualty. The beds are full in majors and casualty because the wards are full, and the wards are full because they can't get people out. So we've got to find a way, not just of increasing the capacity on the tarmac apron, but we've got to find a way of increasing the capacity of going through the hospital. And that's what we were working on today. It isn't going to be a quick fix, but I think we really did make quite a bit of progress today on how we can get all parties working together to make sure that this happens less frequently.
Yeah, I mean, I just to say that I'm really proud of the work the frontline staff are doing in exceptionally challenging circumstances. And we should never forget that. What I think we have to do though is, and a lot of what we've heard is about how we change the fundamental way in which care is planned to live in the health sector. A bit like banking went through, a little bit like retail has gone through, even local government services have changed their approach. Traditionally, we've been what's called a break-fix system. So we typically wait for people to break, or feel like they're about to break, and then we fix them. So most of general practice is reactive, waiting for people to make appointments to come and say, I've got something wrong with me, and then we general practitioners try and fix that person, or they'll bring some support in, or they'll refer them to a specialist if it's a tricky business and they'll try and fix it. But of course it's not an efficient, typically an efficient and effective way. Most people would prefer not to break in the first instance, albeit that we all break ultimately in the end, but most people would prefer to avoid breaking in the first instance, and when they do break, to have quite a rapid, quick, supportive fix at home. You know, you don't have to lug to use a dreadful analogy, you don't want to tumble dryer to a repair shop, you want somebody to come out and support the repair of the tumble dryer at home. So when you look at, again, dreadful analogy, British Gas, I now get pestered by British Gas. I'm on a home care program, and they pester me to have my boiler serviced. And if I don't reply, they phone me and say, we want to come out and service your boiler, really want to come out and service your boiler. And they've obviously worked out that it's much better for them to service the boiler and maintain it than having to wait until the boiler breaks and then come out and be liable for the full cost of the repair. Does that make sense?
Yeah.
And actually, it's not dissimilar in healthcare. It's much better for us to be identifying who are the people who are most likely to be at risk of having a health challenge and proactively seeking to support them in avoiding crisis and avoiding any particular illness or injury than waiting for them to break. And that's changing 50, 60 years of practice. The example I would also give would be snow. So when it snows, 80% of all ambulance conveyances are for falls. Fairly self-evident. But if you think that we have 125 conveyances a day going into Portsmouth Hospital's trust by ambulance, so when it snows, 105 people have fallen over and picked up by ambulance. And actually, those people who are going to fall are broadly predictable. You typically are typically at the older age spectrum, typically living independent lives, many of them living alone, who go about their lives in a normal way, and yet when it snows, they go out to do their usual business, they fall and they injure, and then suddenly that's a catastrophic failure, because it's not just immediate trauma and pain, it's then loss of independence, a spell in hospital, potential coming out and thinking, do I feel able to retain, do I need to go into care sector or not? So we can predict that, we know it the same, and therefore we've got to change our model. So rather than waiting for the 120, 105 conveyances of ambulances, get on the phone, get out there and support people to say, how do you want to be supported so you don't have to go out to get cat food and go shopping today on a snowy day? How do we support you with the right shoes? How do we support you with the right bodying system, neighbours, good neighbour systems, and to avoid, whatever possible, the most catastrophic thing, which is an individual frailty falling over and losing independence, because that's the biggest loss of experience and poor outcomes for people. And that's where the health service has to go. And rather than using lots of general practitioner time, waiting for people to break, we've got to get general practitioner time deployed in stopping people falling in the first place. And that is how we cope with the massive population growth and the massive growth in demand. We don't just get bigger, otherwise I think every school leaver in Hampshire will have to come and work for the NHS over the course of the next decade.